Welcome to the session, What's Ahead for Revenue Cycle and Finance Leaders, Strategies for Current and Future Demands. In this panel discussion, you'll hear health system leaders discuss the latest developments in revenue cycle and finance strategy and innovation. Before we get started, we'd like to thank the sponsor of this session, Guidehouse. Ranked the third largest healthcare management consulting firm in 2021 by Modern Healthcare, the Guidehouse Health team helps hospitals and health systems, government agencies, life sciences, retail companies, and payers solve their most complex issues, overcome unique market challenges, and deliver innovative services to their communities and customers. It's my pleasure to introduce the moderator of this session, Tim Kinney, partner at Guidehouse. Tim, the floor is yours.
Fantastic. Thank you, everybody, and thank you, Modern Healthcare. We really appreciate the opportunity. I'm excited. We have a great panel here, I think, addressing some core issues and pressing challenges that we're seeing with the market. So before we dive in, I do just want to allow each panelist to introduce themselves and the organization which they come from. So Robin, can we start with you?
Sure. I'm Robin Damschroder. I'm the EVP and Chief Financial Officer at Henry Ford Health System. Henry Ford Health System is almost $7 billion. It's an integrated delivery system, and we're located in Southeast and Central Michigan.
Fantastic. Thank you, Robin. Mark?
Hi, good afternoon. Mark Polchinski with UVA Health System. I'm Chief of Rev Cycle, and we're a academic medical center in the Virginia marketplace, serving the Commonwealth of Virginia and elsewhere. Thank you for being here.
Great. Excited to have you. And Rich.
President for St. Luke's University Health Network. We are located in the Great Lehigh Valley in eastern Pennsylvania and service both 11 counties in the Pennsylvania and 1 county in New Jersey. We are 13 hospitals strong and growing, and we are about a $2.5 billion organization.
Great. Well, thank you all, and thank you for your leadership. I know healthcare can be challenging, especially right now as we continue to go through the pandemic. But let's jump into it. We have a good set of questions today, and we'll get started. I think the first question to set the table a bit from a macro level, we have record inflation, we have budget constraints, more and more increased financial pressure for our health systems. We see it in the news, we see it day to day as an industry. I'm curious as we get started, what are some of the most impactful changes you either see now or coming down the pipeline to drive financial and revenue cycle transformation? So Robin, maybe we'll start with you.
Sure. I would pick on 3. I think the labor shortage is going to change our landscape. I'm sure we'll talk throughout the course of this dialogue about automation that's going to be required. I think continued pressures on reimbursement, right, are going to come our way. They're going to push us to evolve. And then finally, the third one that I would pick on is the shift in care models and the competition. So going from inpatient to outpatient to retail, inpatient all the way to home, and then the disruptors that we have out there, particularly in retail and in the physician marketplace, digital and virtual as well, that are going to drive reimbursement down.
Great. No, we're seeing those across the country for sure. Mark, anything to add to that great starting list?
Yeah, Robin really kind of kicked it off, right? The competitive commoditization of care, right, with the retail marketplace is a huge shift in how care is delivered. And we're just going to continue to see that expand, right? The scarcity of labor. She covered, I think, the 4 points I had identified really well.
Great. And then Rich?
Yeah, absolutely. Robin covered the hardest challenges that we face. I also think there's questions around consumer expectation that aren't settled yet. And I don't know that we are necessarily addressing them effectively, but I think that's going to contribute to some of the challenges going forward.
Great.
Yeah, I think that's a good point, Rick. Right, the intense regulatory pressure and the consumerism that's just taken on a whole new life in the last 5 years. That's going to continue. Agree with you completely as well.
Tim, the other one that I would put on there as we talk about it is what's happening with pricing transparency, right? When the hospitals shared their pricing on the 1st of July this year, the insurance companies are going to share their pricing. So I don't see on the horizon anything quick and easy for the consumer in that, but there will be a lot going on in I believe, the contracting side of the house for both payer and provider.
Yeah, you are all absolutely correct, and we'll dive into that. I think transparency is a big one we're seeing across the country, coupled in with no surprises, as you've all articulated here in the start. So let's jump into a little more detail related to some of the concerns and I think challenges that we've seen. So one of the things we're seeing across the country, it's either number one or two, and each of you alluded to it. It is no secret that we have a labor shortage across the country right now. That's clinical, that's within finance, that's within rev cycle. You are all leading large health systems. What are some of the tactics you're using to combat that shortage? Are there partnerships out in the market that maybe you hadn't thought about before, hadn't considered, and it's accelerated? And how's that playing out? What are you looking to in the future? So maybe, Mark, we'll start with this one. We'll start with you on this one for the labor shortage.
Yeah, thank you. If I could just do a little introduction to it, right? The COVID response that most of our systems had really was transformational in that many of our organizations across the nation sent people home, right, quickly. And in my view, we are really lagging the opportunity to have advanced remote work, for organizations, right? So we were lagging, the opportunity in terms of technological advances to have really taken advantage of that without having a crisis force us to do so. Now many of us have done so in coding and things of that area where it was really common. And so that's kind of just a quick note that we really need to optimize the opportunity as technology advances. And often our organizations are risk adverse to adapt new change. So I think that's kind of a lesson learned in all this. But in that, now it's really opened up the courtyard of what's available to us, right? The hybrid model. Where do we insource? Where do we outsource? Where do we maintain teams within our organization doing work? But it's opened up the whole floor, right? We can recruit now nationally for talent. And I think it also opens up the discussion, as we've seen with many organizations, looking at outsourcing as really their model of rev cycle for the future. So, and while I'm not fully advocating that, I think we need to understand where we have the opportunity to improve service to our patients and improve net revenue and manage the cost curve.
Great. Excellent. Robin, curious, are you seeing the same type of thing and approach within your organization?
Yeah, I think we see many similar fronts. I think some comments that I would add to that. In many cases, as we were looking at remote work before, a good chunk of our revenue cycle and IT workforces were already at home before we hit COVID. But again, I'm with Mark. You had to kind of raise the bar, though, the technology and the platforms that you were using. We got to take full advantage of capabilities that we had and that we weren't using. I think the other thing I'm on board with Mark about is you also see this shifting as people don't want to be in contact or call centers anymore. Doing follow-up on billing is a task that people are like, do I want that job or another job? So when we look at outsourcing options, we first got in it to level load, so you could have people working in the evening or on weekends in order to reduce overtime. Now you're really seeing it as a backfill strategy because you can't get people to take your positions. We are looking at it from a point of view that it is maybe a temporary place to be, and it's going to be a bridge to automation. I think Mark was alluding to this. The platforms are becoming very sophisticated. We have lagged behind many industries, whether it's banking, credit cards, retail, in how we are adapting to consumer needs and how they want to interact. And most of the time, they don't even want to talk to somebody on the phone. So how can you get this all done online without having to do that. So I think as we look about making the full transformation, offshoring is going to be something that's going to be used by a bridge by many people, because as folks have already chosen to leave, how are we going to bridge the gap till we get there?
You got it. Well said. And Rich, I know you run a large revenue cycle and financial shop. Same theme you're seeing?
All of the above. I think the other pressure that we're under is the competitive marketplace. Remembering that most of our staff aren't in careers for healthcare. They're just there to put food on the table for their families. And when FedEx or Amazon or some of the other factory warehouses around the Lehigh Valley offer the same salary or same hourly rates as we can offer or more, that becomes a challenge for us. Why go on to and especially over the course of this COVID pandemic and the pressures that were put on some of those front end staff to interact with patients who were that takes a remarkable talent in my mind, and we're paying them $15 an hour. They can go pack boxes for $15 an hour as well, and still bring home the money that they expect to make. So we definitely have implemented certain things like incentive payments, sign-on bonuses, doing market analysis on our salary levels. But I think that's another area that we need to address with the staff that we have to support.
Good deal. Well, I appreciate the thought leadership there. I know I agree. I think one of the positives that have come of this pandemic is catapulting us into the future for healthcare with some of the technology. So as we've lagged behind, it's been good to see, the shift to telehealth, the shift to resourcing, as you guys talked about. We hope it's here to stay. So thank you for that. Let me pull that thread a little bit, and we'll stay. Resourcing is a big piece of this next one, but everywhere we look today, consumer engagement, access to convenient care. I know some of you as panelists have direct oversight. Some are involved, obviously, peripherally, but I'm interested to know what your organizations are doing from an investment perspective in the patient journey as we move and continue to move into this world of consumerism. What are you seeing? Where are you investing? And then I think secondarily, have you seen the expectations change from our consumer and from our patients? So maybe Rich, we'll go back to you and start on this one.
Sure. This is something close to my heart. I've been working on this for about 4 years to engage our patients, to provide them the same self-service opportunities to access healthcare as they would to buy something from Amazon Prime. It should be as easy. It should be as convenient. And especially in the last 2 years where we were trying to do touchless service, provide them the opportunity not to interact too closely with people, I guess. But yeah, we have been working on self-service scheduling, registration, check-in processes for the last several years. It's starting to come to fruition nicely. We are an Epic shop, and we have seen growth in our utilization of MyChart, which is the patient portal for our system. We've seen a 59% increase in our patients who are using that. 55% of our patients are actually MyChart utilization people. We've seen, and recently we've turned all of our primary care and diagnostic services onto online scheduling for those orders that have been placed by our primary care and specialty practices. And we've seen a 200,000 scheduled appointments done by patients themselves, which from our small start in the prior year is up 517%. So we're seeing the growth in that and patients actually taking advantage of that. And it's resulted in significant savings for us in that area, 1.4 million approximately in terms of staff time and no-show rates, because we feel if you're scheduling your own appointment, you're going to keep that appointment. We've also seen 500,000 check-ins. So people are checking in online prior to coming to their hospital tests or their physician appointment, which is also having an impact on our staffing needs in those areas. So anywhere we can engage that patient to provide them a self-service opportunity, we are taking advantage of those, and we are absolutely seeing success in that. We've seen our market share improve dramatically over the last 4 years over our competitors. We are experiencing better than average financial metrics. I think that's a carry through from our patients being committed to what they're scheduling and registering online. And we've obviously seen an increase in our patients utilizing the services. So part of our initiative for over the last 2 years, 3 years, maybe more, has been really getting our patients engaged and providing them the opportunity to do their own scheduling, registration, and now check-in. We are hoping to expand that. We've not gotten our specialties involved at this point 100%. We're slowly moving in that direction. And hopefully we also engage the patient on understanding what authorizations for services mean. And they realize that that's also a component that maybe they should be involved in getting.
I like that, the educational component. Mark, you are leader of an academic medical center, growing as well. Would love to hear your take on consumerism and the growth within your organization.
Right. I'll start with the last question first. We are seeing a dramatic shift in the expectations from our consumers. I think Rich summarized that well, and Robin stated it earlier. They don't want phone calls, right? And so, in fact, when we attempted to make calls just to help people through COVID, they'd want to put us on the do not call list. Right? So which shows, right, the response from our consumer, our patients is, treat me like I can be treated through the retail houses, right, as the Amazon methodology, right? That's changed the nature of how we deliver. And Rich really identified a number of major improvements. We're calling that kind of the digital communication strategy. So how do we create that seamless and timely patient access through their financial journey experience, where we can communicate to the patient in a manner they want to be communicated to? And really deal with the financial care aspect of it. So, right, in our view, and advising a patient before service what their out-of-pocket is has always been leading practice, right? 20 years ago is leading practice. It's just been very complex to do. And now systems like Epic and the communication strategies that are evolved through Epic or other systems allow you to really reach out and connect with that patient. So that's where we're focused on really the front end, but also in the back office side, but really having that seamless communication pathway established as well. So we make it easy for the patient, and they can really self-direct what they need help with and care.
Good deal. And Robin, I know you have a multifaceted system as well. Are you guys working on the same things to drive?
Yeah. Absolutely, and in all the same areas. And I guess that maybe what I would have to add to this conversation, we've really taken a look at it from the whole patient journey perspective. And we view healthcare a lot like banking or the airline industry, right? You have to make the bricks and clicks work together. So if you have a great front door experience in scheduling that online appointment, but you get there and people don't know you're coming, and or when you leave, the payment follow-up is too hard. So we are really trying to look at it from end to end and what that experience feels like. And if people need to make changes, how do we make that easy? When we send the alert out, do we say, oh, if you can't come now, would you like to change your appointment? Here's your options, just as easy as it is to change a flight today. So I think those are the things that we're trying to, as we look at that patient journey and knowing we have to accomplish all those things that are out there. We want to make it as seamless as possible. And again, most of it done right in the palm of your hand, right?
And I would just add to Rich and Robin, they've covered so much, but one of the areas that really integrates with our patient is the payers. And so whether it's governmental or commercial, the lack of standardization there, just the onerous pressure they put on authorizations that are just complex. The patient gets stuck in the middle of that too often. And so we've needed, industry change in that space for many years. And we really have to continue to have a focused effort to bring that standardization about so we don't have different rules and criteria for one payer versus another. And to simplify that process so they can be involved in their authorization, as Rich indicated, right? And right now, there's billions of dollars of expenditure for the healthcare systems and the industry payers in managing the administrative burden of this. And that really is something that needs additional focus as part of our strategic plans for the future.
Perfect. Mark, you led me right to the next topic I wanted to talk about. I think authorization is a key challenge. We've heard that from our panelists. My question is around that intersection of clinical and rev cycle. So what you've seen, where you see it going in the future. We've talked about consumerism and the contact center. We see more and more of a clinical aspect being added up front for the patient experience. We see it as we look at, denial management and some of the tactical things we do in rev cycle. So I'm just curious of your journey. Are you continuing to see that collaboration between clinical and rev cycle? And maybe Mark, we'll go back to you to start.
So over the last 20 years, I think leaders in the industry have really recognized that revenue cycle is really the integration of clinical and financial operations, right? And it covers the entire journey of the patient through our systems, from the beginning of their access or thought to come in, to their services, to the completion of the claim and finalization of that bill, and how do we improve it. So what I've seen in my career is that often we still have many colleagues, including in the revenue cycle space, stuck in silos, right? They're focusing on kind of a departmental perspective and really not taking the time to understand the integration that's required between our operational arms, right? Because our rev cycle undergirds the whole clinical enterprise and it's completely enmeshed in it. And if we don't have that working well, the patient will never be satisfied, nor clinical stakeholders. So I do think there's been improvement, I think there's still tremendous opportunity to really integrate the clinical and financial operations. And that just develops a better service model to our patients and to our colleagues, and reduces that administrative burden that our systems face. So that's kind of my quick comments. I can let Robin and Rich jump in as well on that question.
No, I think that resonates well. Robin, curious from your CFO lens if you're seeing the same type of collaboration needed still.
Still, I think always, and I think it has to just be tighter today than it's ever been. And it's very apparent if you want to get first-time quality and not have to do the rework at the back end of the revenue cycle, you're going to engage your clinicians, the documentation. I'm excited about where technology is going in an effort to, free the workflow of our clinicians from those computers. If we actually, get to have Alexa in the patient room, and you can ask for not only to get historical data, but you can dictate that's going to be great. There's all this AI functionality about helping clinicians with their documentation. And so again, if we can knock down some of the work processes we have in place where we're checking things 2, 3, 4 times before a claim goes out the door clean, that's really important.
Great. And Rich, I know you've been through epic go live after go live with clinicians and finance side. What's your take on it?
Well, I'm excited to hear what Robin just said about Alexa in the exam rooms and forcing that documentation, because you go back to doing root cause analysis on where the denials are coming from, and it always ends at the clinician not having documented or just chose an incorrect diagnosis for a test that they ordered. We've seen much more medical necessity denials in areas of lab, in reductions in levels of service in our ED services from payers, just due to the importance of documentation. And it reminded me how much stress and pressure is put on our clinicians to do the right documentation and the pressure they have to process patients. My son's a third-year medical student, and he thinks I'm the devil incarnate every time I talk about this. So whatever we can do to alleviate some of the requirements that we put on our clinicians so they can actually deliver health care to these patients, that would be the best. And I am going to take what Robin just gave me as a takeaway for me.
Well, hopefully Epic's going to help us because, right, they're developing the ambient technology for those of us who are on Epic. I think we also have an incredible opportunity too, as Epic's looking at this, the payer provider module, when you're trying to adjudicate that admission, because I like to say that the clinicians are trying really hard to deliver for the patient the treatment, doing what they need to do first. And, it's not that this is secondary, but it is secondary, right? For us to get paid. And I think what we can do for real-time exchange between ourselves and payers in the future in an effort to get someone admitted, just think about how much we would save on capacity and throughput if we didn't spend hours waiting for someone to respond back to our clinician.
That's right. And also, right, systems, right? Your system at Henry Ford and St. Luke, right, UVA, right, where you need tertiary care and where you need primary care, and really the integration of using the right service model, right? So not just where we talked about the access and financial care or the digital communications and service strategy, but really how do we really help patients go to a lower cost service setting? Because our primary care operations and our tertiary hospitals will always be less expensive than our tertiary care facilities, or rather our quaternary care facilities for delivering care. And so how do we help guide patients to that best quality, but also best price within our own span? And then that integration of the schedulable orders, as we call it, right? If we know what the patient is going to be receiving, we can deliver really accurate estimates to patient. I think that's where that integration is so key. And then the point that I think we made earlier, really the really consumer sensitive component of pricing, right? It's just so much in the spotlight, and that's just increasing with the shift of out of pocket for the last 5 to 10 years to the patient. That's increasing. That's not going to go away. And so more than ever before, the consumerism has reached a point where they want to know beforehand, and even if they don't, it's really our responsibility to share in advance. So I think those are some points where that integration is needed, just to amplify what Rich and Robin spoke on.
That's great. Fantastic. Well, here's one I've been waiting to ask and very excited to get your guys' input. You don't have to look far to hear about the disruption in healthcare related to automation. And I think everybody's getting into it at a different level on the maturity curve. I'm very interested to hear, what are you guys doing within your organization to drive revenue cycle performance, financial performance? Maybe it's the clinical outcome piece of the puzzle. And a question that's been weighing on my mind too is there a point of diminishing returns? You look in Epic, what you can do, you look maybe with an outside partner. I'm very curious to hear where you guys are in the journey. So maybe Robin, we'll start with you.
Sure. I more so than just revenue cycle, even we're doing this in a number of places. Probably the one that I'm most proud of at the moment is point of use. So when everybody talks about Amazon and what they do, and it actually does tie back to revenue cycle, because you're talking about capturing all the charges you're supposed to capture, and in particular in the OR, the cath lab, and the interventional radiology suites, where everything is so high end, and there's just hundreds of supplies, right? So we've managed to begin that implementation. We built our own inventory system within PeopleSoft. We've tied it into Epic. And so that has gone live, and we'll finish all of our sites by this next June. We're already seeing the effects of getting great data. We're seeing how much more we're capturing in charges that would get left behind just because of human intervention. And I think that story can be replicated time and again. I would agree with Mark's statement earlier that we're behind as an industry. We have people involved in every single one of our processes, and it's probably why this labor shortage hurts the most, right? Other people were prepared. And so we like to talk about not losing the opportunity to take advantage, because again, you don't have people in these roles right now. And so at this point in time, we're trying to find the sweet spots where we can automate as well as raise the quality service experience of the entire outcome that we're trying to achieve.
That's great. Congratulations. And Rich, I know you've been working on this as well. Excited to hear about what you guys are doing.
Well, I'm a skeptic, a long-lived skeptic. My focus in our organization is really to ensure we are optimizing the systems that we have, specifically Epic. There's a lot of untapped opportunities in those systems that I don't think we have taken advantage of as an organization, and I think people are still learning what opportunities there are in their EMR system, whether it's Epic or another. The peripheral automation opportunities, that's where I've been a skeptic. RPA, I'm not sure I've fully bought into it. I've got a number of vendors who've come to me with a consultant in hand to tell me all the savings I can do with automating my authorization or my denial processing. I've not seen it yet work effectively, unfortunately. And maybe that's just me, but I'd rather fine-tune my base system to ensure we're getting the most out of it, because as we grow as an organization, and we have, we've not really added people to support that. We've made sure our systems were supporting that growth. And wherever we do this, we ensure that our operational folks are working hand in glove with our information technology staff so that we are driving the changes, not those changes being driven to us. So me being the skeptic, I'd rather live in my Epic environment, get it fine-tuned correctly, and make it work for us.
I would add, Rich, to that conversation. We remain skeptics of RPA too, and we're looking for the strategies that bridge us to directly to automation. The RPA strategy to us is like a sideshow, and I don't want to call it a gimmick. I mean, some people need it and are going to use it, but it's doing low-level automation of just keyboard tasks, right? And if you truly get back into your system and/or buy a bolt-on, you really have the opportunity to bypass that part of the evolution. And so we, like you, many times, for example, we were using VisiPay because Epic hadn't evolved its technology for online payment. Well, that just changed, right? So I think the danger for a lot of these folks building bolt-ons is that if Epic or Cerner actually surpass them in an individual vertical, customers revert back, right? Because it's more efficient for us. And I think that tenacity to re-look at those options that they're out there are very different than what we used to do, where we used to like really marry ourselves to somebody who had a bolt on and not give it up. And we can't afford to do that anymore, right?
Right. We need to take advantage of the systems we have. And as we see systems evolve over time, they do improve.
Yep.
Now
And that's so true, right? It's so true, though.
I'm kind of outside of my comfort zone when I talk about this, but we are using a lot of artificial intelligence in terms of assisting our clinicians in clinical decision making. We've got an extremely important program going on in that regard, and I say go for it, because that's where we should be investing our money.
So I love what both of you have said, right? I consider myself a pragmatic optimist, right? So, what I like about RPA is that if you have standardized, defined processes, you can then use it effectively. But often there's so much variability within our own span, right? Well, I complained earlier about the payers having increased variability. When we did some reviews of our own when we moved to Epic 5 years ago and said, okay, we've changed our productivity models because we're in a new system. And someone came up and said, well, what about RPA? And I said, well, we need to understand where we have consistent practice first before we move to an automated RPA journey. And when we went through that exercise, it was a bit alarming that we had so much variability across the same job descriptions. And in fact, across our access area, we have something like 270 job descriptions within our health system. And so I think to the point you made, Rich, we've got to remove the variability and standardize our own operations to gain efficiencies. And then as much as possible, let's not RPA archaic business practices. So, right, we talk about what needs to change. I kind of hate automating something that's archaic. 20 years, it should have been changed 20 years ago. So how do we, to your point, Robin, leapfrog ahead? But we're investing in systems that will take us into some of that pathway for authorization, simple auths, because we do have staffing limitations, and we're trying to determine where to use that technology effectively. And I think the other point, well, Epic is really bringing a lot forward. There's still opportunity with a number of bolt-on or third-party apps where Epic is 3, 4, 5 years behind. And I think that becomes the equation we need to look at. Is the opportunity worth the investment in that third-party app to advance the performance until Epic gets there? If Epic's there, fine. But in my view, in the digital communication strategy, they're still lagging the industry. And the question is it 2 to 4 years, or is it 4 or 5 years? If it's 4 to 5 years, probably something for us to consider. And that's how we're looking at kind of the third-party apps integrating into the Epic landscape.
Mark and Rich, the one thing that we also did, we actually transformed our central billing office about 3 years ago. So instead of organizing our teams by payer, they're actually organized by work function. And originally the thought was, we'll just apply some RPA to that. And the variation that you're talking about is what we found that made that not quite possible. But the most amazing thing is it's really getting us ready as we look at technology and automation. And it also allowed us to create a homegrown productivity system that, again, when we went home to work remotely, we had the visibility of how people were working, where they were challenged, what we needed to educate on. So I think in addition, when we talk about just the technology, it's really taking a new look at our processes and how do you prepare for it? Because it's an evolution over time.
Yeah, I agree. And I think going remote without being on Epic would have been extremely difficult for us based on the other system we had pre-Epic. Just that integrated automation allowed us to see the performance, the productivity, that structure, and technology allows us to stay in contact with the remote workforce. So there's huge gains we've made by moving into an Epic environment. As we recall, the way financial systems were disconnected from clinical, now it's just so tightly integrated. To the point earlier, we have to be integrated in our operational model because the system is designed that way.
Great point. Well, thank you all for the insight into the strategy within your organizations. I know that's top of mind for almost everybody I talk to in the industry. So fantastic. Let me come back to an item that we've talked about because it is big. We have the pandemic, as we've talked about. We've talked about the resource shortage. And then let's also throw a couple other big things in there, such as price transparency and no surprises. So I'm curious, front and center for each of you, what has your organization done to address it? I know it's been a heavy lift. And then more importantly, what's been the impact? Has it been positive for patients? Do you foresee it being positive for patients? And Rich, maybe we'll start with you.
Sure. Well, I don't think that the recent legislations, whether it be price transparency last January or no surprise billing this January, and wherever the hell that goes next January, I don't think the patients have bought into it yet. I think our competitors have. I think our payers have. I think the advocacy auditors have, in terms of auditing our compliance with sharing our prices online. And the reporters from the local newspaper. That's it. I don't see it having an impact. Now, that's not to say that we, as a system, as a healthcare system, can't have an impact on price transparency. Several years prior to price transparency, St. Luke's put into place what we call Price Checker, and it's a all-inclusive hospital provider opportunity to buy limited services, whether it's diagnostic or procedural, and be guaranteed a price for it. That works well, and it has worked well, and it was kind of the precursor to price transparency. But it requires some interaction with what we put in place, financial navigators, to assist patients in getting through the chaos and the confusion of what healthcare is to patients. You're putting a list of prices out there, and what Aetna or other managed care payers reimburse us merely confuse the patients more. Why is the charge this? And these payers pay something different. How come? Patients aren't aware of the back office negotiations, the sausage making that goes into manufacturing these contract management deals. And they don't care. All they care about is what's coming out of their pocket. So for us to put those prices out there last January, it didn't mean anything to the consumer. They can look it up and they can see what the charge is, but God knows what they're going to end up paying, because they can't figure out their insurance policies or what their co-insurances or deductibles are, when it's exhausted, when the family versus the individual deductible has exhausted. It takes someone who's going to be able to guide them through that decision-making for financial out-of-pocket responsibilities. Now, if you move that forward a year to now the no surprise billing, people who put that legislation, again, this is my own editorial, people who put that legislation together have no clue about what happens in the healthcare setting. They're well-intended, they're well-intended for what they wanted to do with no surprise billing, but the complications that arise in healthcare because of the differences between us as individuals and how we react or need healthcare makes it a challenge. Now, gratefully, we only need to address those patients who are uninsured at this moment. Yep. But when we have to now go and interact and get confirmation from a payer in advance of providing the service, our providers are not going to like that, because it's going to delay the delivery of care or postpone it or wait until we have an estimated amount out that the patient's going to pay before they receive their service. It's going to get complicated. And if we don't have systems in place that provide that automatic access to an estimate so that the patients can know what they're going to pay and it be correct because they put in the right CPT code or HCPCS code or whatever information they're putting in to bring that estimate back. It's going to be important and it's going to be confusing. Yeah. And I hate this. I feel like I'm the negative nanny here on all these subjects, but it further I think it further distances our ability to relate to our patients when it comes to financial outcome.
Rich, I would agree with you. I think it's well intended, but I think just the self-pay price estimates for the uninsured, right? And any patient, they care about what their out-of-pocket is, not what a payer pays us, right? It's really about what do they have to put on the table to pay for the service, and the price transparency has really moved into a lot of data that's meaningless, to your point, to the patient. The other item in this is that, as we've argued for years, our payers, governmental or commercial, have been collecting and doing actuarial reviews of our payment structure for years. So they have the policy, they have the plan, they know how they're changing their coverage limitations at any time before we do. And so if a patient really wants to know what their out-of-pocket is, the payer is typically the best source for that information. And we really allowed that to be bypassed to put that focus on the hospitals and providers, because I think, frankly, we're an easy target from a legislative body group. So I think we missed the mark legislatively on that, to really not understand the complexities involved and the dependency we have on the insurance carriers to really give appropriate estimates. And then the complexities of really, if you have a new patient visit, what's really going to occur? Well, we don't know, because we don't know the complexity of that patient's health. So we can give an estimate that's a new patient visit, E&M level 1 or 2 or 3 or 5, but blood work gets drawn, x-rays get ordered, right? And so there is so many variabilities in there, and patients understand why it's so complex, right? So we have huge complications coming out, especially as we have to ping the payers, as you said, to get an estimate back to provide to the patient. We've also not seen, we've been doing estimates on our side for 20 years that have been comprehensive estimates upon request or, high out of pocket. With the advent of doing the MyChart estimates online, adding the shoppable services, we've seen a small uptake in patients doing self-estimates, but in my view, it's really not consumer driven until they get the bill, right? Then there's a question of why it's so much. And so there's a disconnect between what legislatively is being ordered and really the patient's interest, which is, I think, the point you're bringing out earlier. So a couple of my quick thoughts to add to the story.
Robin?
Yeah, I would add we've done everything that Rich and Mark have talked about and have the same complexities. I think the one thing we've added to that, we actually save the patient's estimate. So when they actually get their bill and they call us back and they say, you gave me this estimate and you sent me a bill for this, and so that we can actually walk through the differences no matter who the person who did the call. And particularly, we have tried to shift folks online to get their shoppables because it's really labor intensive to provide a comprehensive quote. The other thing, just I would say on this price transparency, the person who's going to benefit as a consumer is the employer to start with. So anybody who is out there driving benefit plans, they now have access. They had access to their own data. Everybody hires very expensive consultants and goes out and looks at the pricing. But what you can start to see, and this is what's going to take a few contracting cycles, right? Like, why does someone in your market pay $5,000 for an MRI and someone else is offering it for $1,000? you can't really understand that unless you understand how they've weighted absolutely every service in their contract. And it's really difficult for an employer to do that. And so I do think it's going to help us as payers, providers, employers to sort of rationalize and come closer or get rid of the variation so that we don't have like such indescribable variations that really aren't supported by much besides what's been a history of contracting with a certain payer over a long period of time to resolve numerous types of issues between the payer and the provider. Again, having nothing to do with the employer or the consumer. So I do think that that's kind of where this all starts. And the patient and the consumer are sort of, the patient as the consumer is sort of put out there as out front. But I don't think I'm with Rich and Mark. I don't think they're going to see the realization of this until we get through a few more cycles.
Yeah, agreed. And then the technological challenges to do it. The shoppable services on our contract management system in Epic and the MyChart functionality works wonderful. The waivers, the communication, the emails, that's really pinned down and really high functioning for us. But it's separate. It's a separate system from the scheduled event. And so those two modules really don't interact. And so the complexity of getting appropriate CPT codes in the scheduled order, right? And then the fact that you need a digital connection because we have up to 1 to 3 days to get in advance. So something as quick as tomorrow potentially requires some estimate. Well, mail services don't work, right? Right. And in our particular region of the country, mail can be a 1 to 2 weeks delay, in the mailbox. And so when you think about how do you make that a timely estimate to a patient, right? There's those types of barriers that require us to really have that MyChart connectivity with our patient population. And many of our uninsured population, many patients are not connected to MyChart, which really makes that process very hard to comply with. You just from that statement of the requirement to get that estimate to the patient timely. So if they're not electronically enabled, right, it's not going to really occur.
Well, I appreciate it. And thank you for bringing into focus the clinician, the patient, Robin, the concept around the cycle to get there. I'm going to do one more question, and then we'll probably have everybody close. Look at your advice for leadership for the future. You guys are all highly regarded, highly successful financial leaders in our health system. So we'll go there, and then we'll close it up. So the question, and we've talked about this a little bit. There's payer provider modules coming out. I understand payer landscape is different by region and where you're at. A lot of shift in payment models. Payer requirements are becoming more and more challenging. I'm curious, within your areas, are you feeling that the relationship is improving as we shift into the future? Is there some good coming out of this technology advances and some of the other things? So maybe Robin, we'll start with you. I know you mentioned it earlier.
Yeah. I think when we look at, can I have you say the question again? I'm sorry. I just got distracted.
No, a combination of payer provider and how you're seeing the ability to work with the payers. Are we seeing any optimism coming into the future?
I'm just going to say no. There's lots of things. There's lots of places for us to come into the same space and work together and integrate, and there'll be technology and platforms that can bring us together. But even during COVID, it's been very quiet, but audits are up and double digit up. Denials are up. So payers haven't been quiet and standing still. I'd like to be more optimistic about that relationship in the future. But, most of us are using some of the same tools, whether you're using an ED analyzer from an unnamed source, and then your payer's using it on the other side. So it's a war of the tools. And I really think we have to ask ourselves if we are going to make forward progress in our relationships and drive down the cost of administration and frustration among the patients. I think we're going to have to come together around this stuff and find a mutual place of agreement to do that. But that's not where we are. And that's even in the midst of COVID, that's not what's been going on. We're not drawn closer together.
Appreciate it. Rich, Mark, seeing the same thing?
Yeah, I think the negotiations for the dollar is becoming more intense, and it's the same dollar. It's not increasing. It's just how you distribute it. Payers are developing narrow channel networks that confuse our front end folks who can't necessarily identify them as such. And we have back end issues with that interaction. As Robin pointed out, our denials are up. Our out of hand reduction in rate are just matter of fact. And you go to appeal it, it's like there is no appeal on this. Very frustrating. And I wonder if this is the storm before it's calm, because I do see a glimmer of hope in that, Epic has created this payer platform that, my skeptical side says all that's going to do is get our denials faster. My positive side says we're going to be able to exchange information a little bit more effectively, and maybe that will foster some better relations between providers and payers. Because all that happens is the patient gets caught in the middle of these relationships, and it's not fair to them because they're not even in the negotiations of this thing. But yeah, I can't. Right now, it's probably not a great environment for provider payers.
Yeah, it's too adversarial to the points you've all made, and there's things that we could have been doing years ago, right? Automation of authorization based upon low denial rates and low fatal denial rates. Those are things that we've been trying to advance for 20 years. We have some payers where they've automated a medical necessity auth process, but it's on a limited subsection of business. But that should be universally deployed. If you have a high level of medical necessity, low fatal denial rate, we could remove so much burden just in that simple area of auths, to the points that my colleagues have made.
Great. No, I agree with that across the board. It's consistent with what we're seeing with denials and write-offs and the challenge. Let me close with this. Advice for future leadership. You guys as healthcare leaders have been dealt a lot. Throw the pandemic on top of it, episodic government events as we talked about it. What do you tell the people you're mentoring? What's an important skill as they come up and look to be our next generation of leaders? And maybe Mark, we'll start with you.
Right. I think we're close on time, so I'll be quick. Our skill set needs to really evolve to match the evolution of the remote workforce, right? They're highly technology enabled. We need to understand how to help manage through that, keep people engaged when they're not in your bricks and mortar setting, right? And so how do you keep the esprit de corps? But I also think that there's core attributes that good leaders have. They really care about what they do. They care about the people they lead. They care about the institutions and community they serve. And if those components are not part of our future generation of leaderships, we're all going to be missing. So we need to really have that type of hardwired passion for the work we do and leadership, and then really thinking and not being afraid to take risks to empower our teams, right? They need to have the ability to take risks and step out and do things that we've not thought of as leaders. And we need to empower them to do so.
Excellent. And then Rich, I know they're not letting you retire. So what would you say?
Well, what Mark has said is fantastic. Where I found it effective in developing staff is ensure they understand what they're being accountable for. As long as they know what they're being accountable for and how they can achieve that, and to give them that ability, the flexibility to pursue it based on what they think is necessary, I think is important.
Great. And Robin, advice for our future leadership?
Yeah, particularly for revenue cycle executives, I have to say you got to get visionary about that future. Think about what it's going to look like. Walk it back to now. What are your milestones to get there? And you need to evaluate people, process, technology, and think about it in a couple of steps of evolution instead of getting overwhelmed with biting it all off at one time.
That's great. Well, with that, Robin, Rich, Mark, I cannot thank you enough. You guys were tremendous. This is the best part of my job when I get to talk to leaders like you. I'm grateful for your leadership, your vision. There's a lot of challenge out there. It's abound, but we are making progress, and it's in part thanks to your great leadership. So thank you again. Thank you for your time. And Modern Healthcare Team, we'll turn it back over to you.
That takes us to the end of this session. Thank you to our speakers for this informative discussion. And thank you again to our sponsor, Guidehouse. For more information about Guidehouse, visit guidehouse.com.